Hi again, I'm Dr. Harry Jacob, the Chief Medical Editor of Hem-Onc Today, and we're delighted to have one of our section editors in lung cancer, Joe Aisner, who's going to discuss with us some of his interests and some of the things he thinks are potentially exciting in the area of particularly lung cancer. Joe, in Hem-Onc Today, we recently did a cover story on the exciting new technology of being able to examine genetic markers and so on in trying to assess in a much more rational way what kind of therapies might be appropriate to a given patient with a given tumor, and as importantly, using this genetic information for prognosticating how patients are going to do, whether they require more massive types of treatments or whether they should be kind of left alone. And I know you've had a very significant interest in that. Tell us a little bit about how genetic studies of tumor cells and of tumors themselves might be helping us make some progress in lung cancer, which has lagged somewhat behind some other neoplasms that all of us are aware of. And then in telling us what the potential benefits are, tell us also where we might have been going wrong in choosing treatment, and how some of this, let's call it pharmacogenetics, if you will, might assist us in not making errors that have been made in a tough disease like lung cancer.
Thank you, Harry. The problem in lung cancer has been that we've treated most of the patients with very toxic therapy, and only a relatively small percentage have a strong response and benefit. Or in other words, we've been treating a lot of people with toxic and what turns out to be ineffective therapy. One of the advances that pharmacogenomics has made for us is that by identifying various phenotypic expression of these genetic abnormalities, we're now able to begin the process that's happened in other tumors, which is start towards individualizing chemotherapy. For example, we've learned that there are some phenotypic expression of genetic abnormalities that will define with great clarity when someone's unlikely to respond to certain therapies, and that would help us to stop or eliminate those toxic, non-effective treatments.
Do you think people involved in lung cancer therapy are particularly prone to grab almost anything off the shelf as of today in so many of these patients who really don't seem to be responding at all to initial therapy, and these kind of genomic studies are going to assist us for not having that happen, both for its economic detriment to the society as a whole, but also to patients' morbidity?
Well, I think it's going, Harry, I think this is going in several directions. The first is that the chemotherapy that's used in lung cancer is composed mostly of doublet chemotherapy, the majority of which use platinum, or one of the platinators, as one of the two couplets. And studies have looked at the comparison of the various couplets, and they've come out more or less the same with respect to response and duration of response, but different with respect to toxicities. What we were talking about before, for example, assaying the tumor for the expression of ERCC1 is a repair enzyme. And when the tumors express that, there's convincing evidence that those tumors will not respond to platinum-based therapy, so that under those circumstances, the individual would get chemotherapy with platinum, wouldn't benefit from the treatment. Whether we can find alternatives remains to be seen, but at least we can spare that percentage of the population from toxic, non-effective therapy. In a similar vein, it looks like RRM1 has negative predictive capabilities for using gemcitabine. So in other words, as we begin to break this giant tumor in non-small cell lung cancer into components, we may be able to begin to individualize therapy, or at the very least, avoid toxic, non-effective therapy. This area also extends into some of the new targeted agents. We know, for example, on a clinical basis, certain targeted agents tend to work well, but we have much greater clarity when we can find the expression of the marker, either by increased gene copy number or mutation in the specific marker, to define the population more likely to respond.